What I'm going to be talking about today is something that, I mean, I'm in this game for a long time, so it could be going to 30 years, and I've always noticed the relapse that I'm going to talk about, but I haven't seen it much in the literature. So I'm going to talk about vertical relapse in orthodontics. It's in the bone grafted area. Now, as you know, we run the Wentworth Foundation, and this project has been published in the South African Dental Journal. So if ever anyone wants to look at it, it's in the July edition of the South African Dental Journal. Now, relapse following orthodontics in non-cleft patient. That means the normal orthodontic treatment that we do in non-clefts. We have lots of instability. We have relapse, and it's it's all the time we're faced with these problems. So with orthodontics, we have this retention phase where we put a retainer in a patient to try and keep the teeth straight. And it's obvious because when you are a baby and you grow to 10 years, you don't look the same. When you go to 18, you don't look the same because changes are taking place in your body all the time, especially in the first 18 years. So that's the critical time for growth changes. Relapse is multifactorial, as we all know. Almost 50% of relapse occurs in the first 2 years after orthodontic treatment. That's normal orthodontics I'm talking about, that we do every day. Relapse following orthodontic treatment is associated mostly with the anterior teeth and especially in the lower anterior segment, because the lower teeth tends to relapse more than the upper. The relapse is in the horizontal plane, anterior, posterior, or lateral. Nowadays, we're talking about when we finish our patients, we do the treatment, we make them look good, and then we tell them, there's your retainer, you wear it. If you want your teeth to stay the same, you wear it forever. So that's the problem now, because permanent retention is becoming a norm. But for cleft lip and palate, it's a different story because the type of relapse, etc., is different. So the collapse of the segments, because when you have a cleft lip palate, you have unilateral cleft, bilateral cleft. So what happens is when there is relapse, it's relapse of the segments, unlike in normal orthodontics where the teeth starts moving and lateral segments getting narrower, etc. But in cleft lip and palate, the right and left segments in bilateral, it's a common feature from childhood where the segments start collapsing. And in view of that, we at Wentworth Foundation, after learning about this and seeing it happening all the time, we have decided that no, we need to start not allowing those segments to collapse, and we want to expand. So I start my orthodontics. Well, we do the children's part first. When they are born, we do nasoalveolar molding, etc. But then when the kid is around 3-4 years old, we start off with expansion devices to start expanding and not allowing the segments to collapse in. And then as we're carrying on waiting for the permanent teeth to come in, we do this, we expand the palate and carry on expanding. And then we enter the fixed phase of treatment where we put fixed appliances and prepare the patient for bone grafting, etc. And then, as you will see in this lecture, we tell the patients from young that you may need jaw surgery. That means orthodontic surgery. You may need revision surgery for the nose, but this can be done at 18. You may need to be retreated for your braces at the age of 18 because of vertical relapse. And I'll show you now what I mean by that. Now, these are the appliances that we use. We're basically using two types of appliance, three types actually. The midline expansion screw, running along the cleft area, the V expansion screw, and the three-way expansion screw. Now, orthodontic relapse for clefts, like in the literature, when I sort of Google and search, I don't find much in the literature to show the orthodontic aspect of relapse for cleft lip and palate. But I did find Talat and Gunaid, who stated that strong tendency for transverse relapse in intercanine and intermolar width. Right, so that's something that we've noticed. To date, most studies on relapse is related to surgical relapse when it comes to clefts. The literature shows few studies on orthodontic relapse. There is no reported study to show that there is vertical relapse. Now, what we are going to talk about is not a scientifically done thing. It's an observation that we have observed over the last 25, 30 years. So I've decided from all the records that I've had, and I've seen this relapse taking place, I've selected 4 cases, and I'm going to show you what I mean and what I'm talking about. 4 cases have been included in the study. 2 unilateral cleft lip alveolus. That means it's a cleft of the lip and the alveolus. 1 unilateral cleft lip and palate complete, and 1 bilateral cleft lip palate. And these 4 growing patients, I started the treatment around 6-7 years of age. Now, amazingly, all 4 cases did not require any jaw surgery, but they did require revision surgery for the nose. So you can see that the orthodontic prevented jaw surgery from taking place. Bone grafts were undertaken when the laterals or canines show signs of eruption. We time it very well so that when 2/3 of the root is formed, we decide when do we get in, and we think about, is it for the laterals or is it for the canines? So we have to make a decision on when to get in. All cases were taken to completion. All these 4 cases, we started them off as a small kid, and we took them right through up until the age of about 17, 18. After this study, once we've seen all the problems, the Wentworth Foundation developed a new protocol. When we remove braces for cleft lip and palate patients, we are now deciding, or we have decided, and we have done a lot, but it takes quite a lot of time to do this. We are putting fixed upper retainers using fixed rectangular braided wires. This is the first case that I'm going to show you. Now, this kid here, as you can see from the Panorex X-ray, this is the early mixed dentition stage. Now you can see this kid is about 6 or 7 years old. So it's a unilateral cleft lip alveolus. That means the cleft is not through the palate. But what I want you to look here, there is an extra tooth that's just distal to the central, the rotated central incisor, and there's an extra tooth lying there. And I'm going to show you what we do when we are attending to that problem where there's an extra tooth. We sort of make it help us. Now, this is what this patient had to go through. After the expansion with the removable appliances, we went on to fixed appliances. And then we put protraction arches, and then we made space for this extra tooth and wanted to let it come down. The reason being, when that extra tooth is brought down, it brings down alveolar bone with it. So that means when the bone graft is done, there is little extra bone. If, let's say, we extracted this extra tooth before the bone graft, we could have created a fistula in that area. So what we do, we get the patient ready for the bone graft. Here now you can see the bone graft was done, that extra tooth was removed, and now the canines are coming down and everything is looking fine, as you can see here, although the oral hygiene wasn't too good here. But in any case, everything looked fine. And the cleft is between the central and the lateral. As you can see there, is between the central and the lateral, right? There's this patient finished off absolutely beautifully, beautiful occlusion. And this is on the day that we took out the braces. And you can see that the gums are swollen. But one thing I noticed that got my mind ticking is the gingival margin. I was wondering, why are these two gingival margins higher up than the rest? So I looked at it, and we put this kid on a wraparound retainer, and we told the kid, right, now this is what you have to wear, otherwise your teeth is going to relapse. So we put this kid on and got this kid to wear this retainer, and 6 months later, when I saw the kid, I noticed something, that gingival margin has gone higher, and I noticed that these two, the central incisor and the lateral incisor, have moved up, or it didn't move down. Because remember, in growing kids, the teeth continues to erupt. So I called the patient back after a year, and I noticed that it's gone worse. So that now that has gone way up, and the kid is wearing a retainer. So this retainer that we make normally for orthodontics is to prevent lateral relapse and antero-posterior relapse, but it's not preventing the vertical relapse. So now what we did, we decided to retreat this kid when he was grown up. We got him back to a beautiful occlusion, and then we said fixed retainer. Now in this case here, we put only on 3 teeth, which wasn't a good idea. We should have done it from the 4 to 4. But we put this, and then we told the kid that, look, you wear the retainer, and if you have a problem, you get back to us. Now, here's a second case, also unilateral cleft lip alveolus, not of the palate. Now, this kid here, as you can see in the Panorix X-ray, this is very early mixed dentition stage. That means that this kid is around 6 or 7 years of age. So as usual, we started off with our removable expanders, and after expanding with a V expansion device, we continued expanding, and then we prevented the relapse of the minor segments, and then we proceeded to fixed orthodontics when the lateral incisor was erupting. And you can see that at this stage here, the lateral incisor does not have a root. So you can't do the bone graft now. You've got to wait for the root to be almost 2/3. Then you send the patient in for the graft. So that's what we did. We did the bone graft, everything done properly, orthodontics, and here's the patient, finished absolutely beautifully, looks good. And we put this patient on a retention appliance, which was a Holly type of appliance. And we told the patient, okay, we'll see you back in 6 months or 1 year. And when the kid came back after 1 year, look at there, you can see that the teeth in the cleft area has just crumbled in, and it's rotated. So what has done that to it? Why is it doing that? So that is something that I've been trying to fathom out. So what we did here, we got back onto the upper arch, retreated this patient, got everything aligned. Once everything was aligned, we put in a new retainer, which is a wraparound type of retainer. And we told the patient, okay, you wear this and get back to us at the age of 15 or 16, we'll check. And then we warned the patient, when you turn 18, we may need to put braces back into your mouth and realign and put fixed upper retainers. So we did that for this patient. Now we increase the length of the bonder braid. Remember, you got to put a rectangular bonder braid wire. If you don't put a proper wire, the teeth will shift. Now, here's a case that is a complete unilateral cleft lip palate. And this patient here, you can see, is in total class 3. That means the upper teeth is way behind and the cleft segment is collapsed in. And this patient also has an extra tooth in the cleft area, which I'm going to show you just now. So we started the removable expansion at 6-7 years of age. And we in this patient here, we put a 3-way type of expansion plate so that we can expand sideways and forward. So we got it going, and then we moved into the fixed phase when this patient was getting ready for bone grafting. So we put fixed appliances, and then that extra tooth that this patient had, we did not extract it. What we decided to do was to bring it down, erupt that tooth into this area here. So we brought it down, and you can see here that tooth coming down brought down alveolar bone. If that tooth was extracted, it would have required more bone to be placed in. But with this thing being brought down, and then what we do, we send the patient for bone grafting. And when we do send the patient for bone grafting, we tell the maxillofacial surgeon, please extract that extra tooth when you're doing the grafting. And that's exactly what happened in this patient's case, where the tooth was extracted after the graft was done. So this patient's bone graft is done, everything is looking fine. We close the spaces, and look at there, this patient looks absolutely good. What this patient needed, which we don't hop in immediately, is gingivectomy. In other words, to get the gingival margins right. So we said, no, that we do later. So we put this patient on a retainer, and then we told the patient, okay, you come back in 6 months. When we saw the patient in 6 months, we noticed something happening. So we tightened the labial bows and readjusted, and we said, okay, right, let's see. And then we said, okay, come back after 1 year. And we noticed that it's not moving laterally, but it's moving upwards. So we told the patient, okay, now this is a problem and we'll need to see you again. So 2 years down the line, this is how that was. So we decided we had to put braces back into this patient model, banded the upper, we realigned the teeth, we put this patient onto a fixed upper retainer, gave the patient a removable retainer and told the patient, remember, at the age of 18, you may need braces again in your mouth. Now, this is case 4. It's a bilateral cleft lip palate case. This is the last case that I'm showing you. Now, as you can see here, this premaxilla was mobile. You can see here. And the bilateral segments were in. That means it was relapsed in. So this patient had a severe class 3 problem. So, and also you will see on the x-rays, the patient is missing lateral incisors. There's no lateral incisors. So what we did for this patient, we got a 3-way removable expansion device, and we started expanding because the patient was about 6 years old or 7 years old. And we started expanding and carried on until the patient reached the stage where they needed fixed appliances. Now, during the fixed appliance, we also put an expansion device in the upper jaw because as much as we expanded with a removable, we didn't get the sufficient expansion. So we put in fixed expansion and expanded furthermore. And this is all before the bone grafting. Okay, so remember, there is a lesson. You must always do your bone grafting after you have set the teeth in position. So we send the patient for bone grafting and then had the bone grafts done. Once everything is done, we remove the braces and then we put the patient on a removable retainer with partial denture. In other words, teeth on the retainer. And when we looked at it, she looked quite good and she was very happy with it. As you can see here, now it was the same patient that was a total class 3 with the maxilla completely retracted and the bilateral segments completely collapsed. So now this patient is looking good. However, when we see this patient 1 year later, now remember that the premaxilla, there's only 2 teeth in the premaxilla. Okay, the laterals are missing. Now the bone graft was done. The premaxilla became quite sturdy and it attached quite firmly. So now we decided, okay, we told the patient, all right, when you turn 17 or 18, you can have bridge work done. We don't put implants into cleft areas. We had too many failures. So we said, okay, come back in another year's time. This patient never came back, but came back to us in 5 years' time to tell us that she's ready for the bridge work. But this is how she looked. So now we told the patient that you need braces again. We need to realign your teeth. And I think this time you can go ahead and do the bridge work. Okay, so that's the cases that I want to show you. And this is the thing that we are seeing. So what have we done? We have developed a new protocol at our clinic for growing patients. We do fixed retention and we're putting at least on 3 teeth of either side of the cleft with a fixed retainer. And then we're observing these patients over time until they turn 18 years of age. We also reassess for retreatment and bone grafting and investigation to appropriate age for bone grafting. So that's my talk today, but there is something else that we all need to look at. And I've been trying to get my hands on it, and I'm working with a good maxillofacial surgeon who is involved in our clinic, and he has indicated to me that whenever he has taken bone from the jaw, like the symphysis or the ramus, and close to the alveolar ridge of the jaw, and used that bone to graft into the cleft area, it seems that it looks better, and it seems that the relapse tendency is not that great. So I don't know. There needs to be a lot of research done to get this side right, where in future, when bone grafts are done, instead of taking it from the iliac crest, rather take it from the jawbone. And I must thank you for that. And I must thank Smile Train for giving me the opportunity of showing our foundation and the work we are doing as far as orthodontics is concerned. Thank you.
Thank you very much, Dr. Sain, for this wonderful presentation, which was very brief. And with the cases that you presented, I don't know, I'm still looking for questions, and on the questions Q&A. I don't know, is there any of the panelists, Professor Ade Tokumbo, are you there? Do you have something you want to say while we are waiting for the questions and the comments?
Thank you very much. Just to thank Dr. Sain for this practical demonstration of cases he has seen, and for us to appreciate the challenges of orthodontic treatment, so that it's a collaborative thing between the surgeons. It's not just, when you are dealing with cleft, it's a multidisciplinary thing. So that we should try to develop our team care and also have all the specialties that are involved, especially the orthodontists. They see the patients longest, so they should be involved right from start to the end of this management. So all members should encourage comprehensive care and also try to build a team approach to our services. Thank you very much.
Thank you.
Thank you, Prof, for that comment. Dr. Sain, I have some few questions to you, because the attendees are made up of people from various disciplines. There are some key terms which I would like you to define for us, like when you talk about relapse, when you talk about relapse and you talk about regression, and can you tell us exactly what you meant by that?
Sort of relapse and?
Yes, relapse and then yes.
Oh, and regression.
And regression,
okay.
Yes.
Yes, you see, this is what it's really amazing. I don't know whether it's relapse, whether the teeth is relapsing upwards, or whether it's failing to erupt. Because remember, that teeth continues to erupt right up until 14, 15, 16 years of age. So it's erupting vertically. So I don't know whether it's relapsing upwards or whether it's failing to erupt. That's the thing, And that's why I said it's good to do. There is a need for scientific study to assess and see exactly what it is, because if it is failure to erupt, that means the teeth won't erupt through iliac crest bone. So, it's rather, if one does iliac crest bone graft, then it's best done when the teeth have erupted. That means when the patient is around 17 or 18 years old. But then doing iliac crest bone graft at the young age of 11, 12, may present a problem as opposed to alveolar bone. But then again, I must emphasize, I got no stats to prove anything.
Yes, Dr. Sen, you brought up a very important issue and about the alveolar bone and the iliac crest bone. And I don't know, I think that is an area where some studies have to be done. Does it have to do something with the niche theory or the ground substance of the iliac bone and the iliac crest that is different, that allows the teeth to erupt in one and does not erupt beautifully in the other? Now, if you look at the first patient you presented, have you had time to look at that patient of recent? Have you seen the patient again, how the patient is doing?
You mean, have I seen the
boy,
patient?
the young man you started seeing at the age of 6 years old. Did you see him again to see how he's doing now?
No, I'm actually going to give him a call. This is it is a problem because orthodontic patients, they are seen over many years, and then they get lost and they've gone to work or they've gone overseas. But he's an adult now. He's around 20. Yeah. Chad Davis, yeah, he's around 20 now. So yeah, I think we did see him last year. But his teeth is looking. I think his teeth is looking good because I told him that if he sees what I showed him happening to his teeth, he must please come back. And he hasn't come back. So that shows that that problem won't happen when the patient is above 18, 19, 20.
But I want to confess that those your results are really, very fantastic. If you look at where the patient is coming from and where the patient is now, we want to say thank you and congratulations, and that you keep doing the good work that you're doing. Dr. Eric Rakotumalalia, please permit me if I forgive me if I don't call your name very correctly, has put up a question. He said, what do you advise to keep bone graft well alive? He said, what do you advise to keep bone graft well alive? Thank you, Eric from Madagascar. So he's coming from Madagascar. So what do you advise? How do you keep bone graft well alive?
Okay, now, you see, number one, you must have your teeth set, your arches aligned. And when you're setting the teeth in orthodontics, you don't set the teeth like how you're doing normal orthodontics. When brackets are being placed on teeth adjacent to the cleft, one cannot place torqued brackets and angulated brackets, etc. Because if you move the root into a bone grafted area too soon, you will find that it will start degenerating the bone graft. Now, when we do our bone grafts, we make sure that our roots are completely diverged, not anywhere near the graft. The bone graft is done, and then we wait for 6 months before we start torquing the roots into the grafted area. And that is why I told you that it's a risk to put implants into grafted area, because that implant will disappear, the bone graft will disappear. So always remember that after doing a graft, don't touch any teeth and move teeth into the grafted area. You got to wait. You got to wait. We wait for almost 6 months just to be on the safe side. Thanks.
Thank you for that expert opinion. God bless you, sir. Dr. Gaitang Chaka Mapoli is writing, quel est le moment idéal pour procéder au greffe? Est-il avant ou après? Et quel sera le matériel idéal pour le cas de fente? So what is the ideal time to do a bone graft? Is it before or after extension? And what kind of ideal material do you envisage for the cases of cleft lips?
You see, the ideal time is variable. Now, one thing that must be done, and I want to stress this, that before you cannot do a bone graft and then start expanding the jaw. The graft will fail. You got to do the alignment of the teeth, the expansion, everything must be done. And then once it's all done, and the way and how to know when to start doing the bone graft, you got to look at where the cleft is. If the cleft is between the central incisor and the lateral incisor, then you got to do the graft earlier. In other words, in the early mixed dentition stage of development. In other words, to get the lateral incisor in place. If the cleft is between the lateral incisor and the canine, then you have to wait for the canine to erupt, which is around 12 years of age, and which is much later. So you watch the canine's root. If the canine's root is more than 2/3 formed, then you got to get in and do your bone graft. And at the early ages, in other words, prior to, during the growing phase, in all my experience thus far, I feel that the material, the bone material that must be used must be from the patient. In other words, either iliac crest or mandibular bone or alveolar bone. But later, when the kid is over 18 years, one can use other bone, bone from that's prepared elsewhere. Okay.
Thank you,
Thanks.
Dr. Singh. That is an expert opinion. Dr. Hurik from Madagascar says, wonderful tips. Thank you so much. On the comments, I can see some wonderful comments from our own mother, Ma Obi, to all the panelists and the attendees. Say, thanks very much for a brilliant presentation. In fact, Dr. Singh, we are really, really happy. And she calls you Tiki. That's a very good name. I take that, Maobi, very seriously. Now, from Angela Harris, he said, thank you, Dr. Singh, a very informative and interesting presentation. Very useful and practical information for orthodontic management of these challenging cases. Thank you for highlighting how to deal with relapse and failure of eruption, and also posing questions which will hopefully lead to research projects. In fact, just as I said, Dr. Singh, that problem that you pose is a very big thing. We want to know why alveolar bone will allow eruptions and iliac crest bone will not. Do you have any idea, Dr. Singh? Do you have any way, do you have any proposal for a research like that?
Okay, alveolar bone is totally different from iliac crest bone. Alveolar bone vanishes if there's no teeth. You get me? Resorption, yes. If there's no teeth in the jaw, I mean, let's say lower jaw, yes. Let's say the lower left molar is gone and the patient is without a molar for 2-3 years, the alveolar bone will disappear. And that is not the case with any other part of the body. Alveolar bone is totally something else. So that is why research needs to be done, and we need to look at this in a way where changes can be made on how to graft. And because I must tell you, from the time I started with cleft lip and palate, I had so many failures, so many grafts failing, fistulas forming, and I must tell you, cleft lip and palate is one of the most difficult things to treat. I've done a lot of things in orthodontics and everything else, but every time I look at a cleft patient, it's a challenge. Thanks, man.
I have another question I want to ask Dr. Singh. When you look at the consistency of the gram substance or whatever you want to call of the alveolar bone macroscopically, and you take the iliac crest bone, I've never taken an alveolar bone. So macroscopically, when you look at it, do you find any difference in the consistency with that of the iliac crest that can give you a clue that maybe there's something in the matrix of the bone that is probably doing this, so that one can start looking at that very closely?
No, I actually don't have, I don't have that knowledge, the microscopic assessment. I'm just talking, broadly because of what I've read about the fact that alveolar bone is different. It's not like any other bone in the body, and that's the thing. But I haven't seen anything or read anything about the microscopic differences. Now these are areas where people need to start looking at and doing some research to check exactly what's the differences and why teeth moves through alveolar bone and why wouldn't it move through any other bone.
That is very interesting. Dr. Gaitang Shaka Mapoli is saying thank you very much to Dr. Singh and to everyone. Please keep your questions coming. We still have some time. It's a very interesting topic. We're talking about tooth eruption on the grafted bone, and we have a very expert opinion. I have met Dr. Singh on several, I think 3 times, and I really, really enjoy the knowledge that we are getting from him. So please keep your questions coming. And if you have a comment you want to share, I'm sure there are orthodontics in the attendees. Please you are free to, so that we can share your comments and with the rest of everyone. I think Dr. Nicole is saying, yeah. Okay. Okay, thank you so very much. Okay, I want to say, Dr. Singh, thank you so much for everything. Thank you for making our time to teach us.